Okay, it's 8 o'clock. Why don't we get started? Um, Most of you will know who I am, but my name is Satish Raj. I'm a uh, cardiac arrhythmia physician here in Calgary and professor of cardiac sciences. And it's my distinct pleasure today to introduce Miss Kate Bourne as our speaker for cardiac sciences grand rounds today. She'll be discussing postural tachycardia syndrome. Kate is a PhD student in my lab. She has done a fair bit of work on postural tachycardia syndrome, some of which you'll see today. She came as a master's student and really embraced clinical research and has done a phenomenal job. Um, she's made many presentations at both national and international meetings and is developing quite a reputation uh, for this research on her own. Um, but one of the interesting things about Kate is that as great as she's been from a research point of view, she may be a better citizen overall. She has dedicated a good portion of her life to helping others. She is trained as in emergency support and has worked with the University of Calgary Student Emergency Response Group since arriving. She was actually at the London Olympics as a volunteer to help with emergency support, and she's been very involved with the Girl Guides program. And as a reflection of this, earlier this last year, she received a CIHR Vanier Award for Leadership for PhD students. It's a very prestigious award that is involves an intricate and multi-step application process through the main campus. In fact, in Libin, we were honored to have two of our phenomenal students receive the award this last year, really a reflection of the quality people that we get here at Libin. Um, However, I don't think Kate's going to talk about all of that. You're free to ask questions about that. What she is going to share with you is a bit of an overview of POTS, but then really try to hone in on some of the more recent insights that she has developed here, including one that has very recently resulted in a paper accepted to the Journal of the American College of Cardiology. So with that, Kate, take it away.
Thank you, Dr. Raj, for the introduction. So as Dr. Raj mentioned, we'll be talking a little bit about POTS in general and then some recent research findings from some projects I've been working on. So just to provide an outline of the talk this morning. So as I mentioned, some background about POTS, and then we'll talk about the diagnosis and impact of POTS survey, which is a large international survey of POTS patients. We'll then move on to some information about non-pharmacological management of POTS and specifically looking at compression garments as a treatment. And then we'll just sort of wrap up at the end. So jumping right into the background. So what is postural tachycardia syndrome, or POTS? So it's a chronic form of orthostatic intolerance. So when you stand up, a healthy person or someone with POTS, gravity pulls blood from your chest down into your lower abdomen and legs. But in a healthy person, through the baroreflex mechanisms, your body is able to adjust for this and you're able to stand without symptoms. But unfortunately for patients with POTS, something there has gone wrong. And so basically they feel horrible when they're standing, which is quite a debilitating problem. Research has actually shown that quality of life in POTS patients is comparable to patients with congestive heart failure, as well as COPD. And I think that's something that maybe is not as recognized as how debilitating this disorder can be. It's estimated to affect 1 to 3 million Americans, and upwards of 90% of the patients are female. We also say POTS is of heterogeneous origin with multiple causative pathologies, meaning that POTS isn't just one thing, but it's likely multiple things leading to this end presentation. So looking at the diagnostic criteria for POTS. So the first criteria is that when patients are upright, they must have a heart rate increase of 30 beats per minute or more within 10 minutes of upright posture. And this is for adult patients. For pediatric patients, this is an increase of 40 beats per minute. And it's important that this heart rate increase occurs independent of orthostatic hypotension. So there can't be any blood pressure drop defined by a greater than 20 over 10 millimeters of mercury to meet the POTS diagnostic criteria. In addition to the heart rate criteria, patients must also have orthostatic symptoms. So symptoms like lightheadedness, nausea, blurry vision, difficulty thinking properly, headache, that are worse when the patient is upright and resolve when the patient is sitting or supine. Additionally, these symptoms need to be chronic. So it's probably likely that if you've had a cold or a flu, you've felt this way, but probably only for a week or two and then it resolves. So it's important when diagnosing POTS that we make sure that this is actually a chronic condition and not an acute result of some sort of flu or cold or some sort of a viral illness. So we say the symptoms should persist for 3 to 6 months, and other causes of tachycardia, medications, other medical conditions should be ruled out before a diagnosis of POTS is made. And then this figure here, we just have some results of some tilt table tests. So both for a POTS patient and a control, you can see here, this is when the tilt table is tilted upright to simulate standing. And we can see with the heart rate in the POTS patient, it approaches 200 beats per minute. So we see a significant increase there. Whereas in the control patient or control person, there's just a slight increase, which is normal. And then we also see that there isn't any significant blood pressure decrease. So this would be an expected tilt table test finding for a patient with POTS. So what causes POTS? So as I mentioned, it's of heterogeneous origin, and there are likely multiple causative pathologies. So there are likely multiple things going on leading to this end presentation. So this isn't something that's fully understood yet, but there are some interesting physiological findings that show that POTS patients are different than healthy controls. So the first one is hypovolemia. So research has shown that POTS patients have a reduced blood volume. And in addition to that, they also have reduced plasma renin and aldosterone activity. So in addition to lower blood volume, the components that should increase your blood volume are also reduced. So something is disrupted there in terms of regulating blood volume. Additionally, some patients have a hyperadrenergic phenotype, so they have very high plasma catecholamines. In some cases, a norepinephrine transporter deficiency, a point mutation, has been identified, which would impair the ability of norepinephrine to be reuptake to happen from the synapse. But I think that this is still sort of under investigation as to why some other patients might experience this. Some patients have neuropathy, so a small fiber neuropathy. So there's damage to the sympathetic nerves, particularly in the legs, and therefore the body isn't able to respond properly with venoconstriction when there might be some sort of orthostatic stress occurring. Deconditioning, so research has also shown that POTS patients have reduced LV mass, as well as reduced stroke volume and blood volume. And so that's another finding as well. And then finally, some autoimmune findings. So some recent research has shown autoantibodies to the alpha adrenergic and beta adrenergic receptors. And this is definitely something that's still under investigation, but interesting findings there in terms of an autoimmune component to POTS. So some people tend to think of POTS as different subtypes. So hyperadrenergic, that's a high plasma catecholamines, the neuropathic findings, and the hypovolemic findings, and they like to think of them as separate entities. But it's more appropriate to think of them as overlapping. And so we like to steer away from any sort of subtyping of POTS because it's most likely that patients have features from more than one of these pathological findings. So considering them all as overlapping is sort of a more appropriate approach when thinking of causes of POTS. What's also interesting is that in addition to those orthostatic symptoms I mentioned, lightheadedness, shaking, palpitations, chest pain, shortness of breath, headache, things that we consider sort of classic POTS symptoms, some POTS patients also demonstrate these non-cardiovascular symptoms. And in some cases, they can be severely debilitating and maybe almost more debilitating than the tachycardia and those orthostatic symptoms. And so these include things like gastrointestinal symptoms, gastroparesis, which is actually like paralysis of the stomach, allergic symptoms, which can be flushing all the way through to full anaphylaxis, neurological symptoms, headache, chronic migraine is very common, chronic pain and joint hypermobility, and then GU symptoms. So not all POTS patients have this, but some POTS patients have these additional, in some cases, very debilitating symptoms. Something that's still under investigation about why. Additionally, some patients have comorbidities that are seen commonly. So chronic migraine is seen in 40% of participants. Ehlers-Danlos Syndrome, which is a connective tissue disorder I'll speak more about in a few slides, is found in 25%, chronic fatigue syndrome, fibromyalgia, autoimmune disorders, and then mast cell activation syndrome, which is an allergic disorder. So again, some POTS patients have these, but not all, and definitely something that warrants further research to understand why. So as the result of that, of the fact that some patients have these additional symptoms and these additional comorbidities, the CCS created a position statement that was released last year, and this was in part led by Dr. Raj as well as Dr. Sheldon. And so this was an attempt, and it's a very comprehensive statement looking at treatment and diagnosis and many aspects, but they were attempting to look at the difference between patients who have POTS with classic orthostatic symptoms, and then these other patients who have POTS with classic orthostatic symptoms, plus these debilitating symptoms and or comorbid conditions. And so that's sort of what's shown here. So this line here just represents the heart rate criteria for POTS. So if you're above this line, it means that you met that heart rate criteria. If you're below, you didn't. So here we have classic POTS and then POTS plus, which is patients who have POTS plus those debilitating symptoms or chronic comorbidities. And then what's also they're attempting to look at here is that some patients have orthostatic intolerance, they have the symptoms, they have those additional non-cardiovascular symptoms, they have the comorbidities, but they don't meet the heart rate criteria. So they still feel awful, but they're not quite meeting that heart rate criteria. So that's what postural symptoms without tachycardia is, or PSWT plus. So I think an important step at considering what is happening here, obviously patients who don't meet the heart rate criteria, but they still feel awful, it's not a great situation for them. So more research is sort of required to understand what might be going on there mechanistically. One thing I wanted to quickly cover as well is the difference between POTS and orthostatic hypotension, and this might be something that everyone already knows, but just in case not, I wanted to include it, as it does seem to be an area of confusion sometimes. So in orthostatic hypotension, with upright posture, patients have a sustained reduction in blood pressure of 20/10 millimeters of mercury or more. This can be symptomatic or asymptomatic, so a little bit different than POTS where you need symptoms to meet the criteria. And there can be both neurogenic and non-neurogenic causes. So there can be actually an intrinsic problem with the autonomic nervous system, or other things like low blood volume or a medication can cause that. And so just a little bit more about the difference between POTS and OH. So POTS patients, they're primarily females of childbearing age. So you can be a male and have POTS, you can be a bit older and have POTS, but the majority of patients are females of childbearing age, whereas orthostatic hypotension becomes more common as adults become older. Additionally, in POTS, you have to have tachycardia without hypotension. So if you have orthostatic hypotension always, you actually don't meet the criteria for POTS. Whereas in orthostatic hypotension, you have hypotension with possible reflex tachycardia, but it's really that hypotension that's sort of the key aspect there. Additionally, a minority of POTS patients might have syncope, and then falls are common in orthostatic hypotension in older populations. So patients with POTS may experience OH at times, and this is something that I've heard come up quite a bit in terms of a POTS patient saying like, oh, one time I had OH, does that mean I don't have POTS at all? And that's not true. It's only if the orthostatic tachycardia is always in response to OH, then OH might be a more appropriate diagnosis. But POTS patients may experience OH at times. I also wanted to include a note about initial orthostatic hypotension, as this is something that is common in younger populations and common in the demographic age demographic of POTS. So this is a systolic blood pressure decrease of 40 millimeters of mercury, or a diastolic blood pressure decrease of 20 millimeters of mercury right away when standing. That rapidly recovers within 30 seconds. And so patients report they have lightheadedness, blurry vision, nausea. I know at least one person has told me that their vision completely goes away, which sounds very stressful. It can lead to syncope in some cases, and as I mentioned, it's more common in younger populations. So we can see here in this figure, so this is a person who's lying down, they've stood up, and you can see this big blood pressure drop with a quick recovery, and then they're okay. Whereas in classic OH, you can see the person stands up and their blood pressure just keeps getting lower and lower. So I just wanted to include that, as well as I know, at least clinically, Dr. Raj mentions that it does come up quite often in his clinic. Another misconception that I hear often is that you must faint to have POTS, but this is not actually true. So POTS is primarily a disorder of feeling faint, but not actually fainting. So patients feel like they're going to faint and they keep feeling like they're going to faint, but they usually don't actually faint. Some patients might experience syncope, but it is at similar rates to the general population. So what I've heard before is about 30%. And this is a slide from Dr. Raj, just looking at some symptoms. So this is a symptom score where if you had a bigger number, you felt worse, and a smaller number, you felt better. And you can see for this sort of long tilt here, POTS patients continue to have pretty significant symptoms throughout the tilt. So they were sort of continuously feeling awful and feeling like they're going to faint, but that persisted. More than leading to syncope is that they just felt pre-syncopal for long periods of time. So that was just a very quick overview of some background about POTS, and now I'll be moving into some more details about the projects that I've been working on. So what is the diagnosis and impact of POTS? So it's also known, or we call it as the Big POTS Survey. And this is a survey that was developed in partnership with Vanderbilt University, as well as Dysautonomia International, which is a patient group for POTS as well as other autonomic disorders. And then as Dr. Raj moved from Vanderbilt up here to Calgary, we're now involved, and I've been fortunate to be able to work on this project, doing some data analysis and looking at this survey. So this is a survey where data collection began in July 2015, and it's still ongoing, so enrollment is still open. It was a patient community-based cross-sectional survey where we just surveyed patients one time. And participants self-reported a physician diagnosis of POTS as well as other medical and social information. And so this was a very comprehensive survey. Some patients reported it took them up to an hour and a half to complete. So it covered a lot of details from diagnosis challenges, medications, treatments, social impacts, quality of life, really tried to capture many aspects of the POTS patient experience. And it was something that the Dysautonomia International Patient Advisory Board played a role in ensuring that the questions asked were meaningful to POTS patients. So the main paper for this survey was published in 2019, and it was led by Dr. Brett Shaw, who is now an emergency medicine resident here in Calgary. And this provided an overview of some of the highlights of the survey and maybe the most important points, just to provide a general overview. So for this paper, there was a total of about 4,800 participants. Because the enrollment is still going, we actually have almost 8,000 participants now. Majority of participants were female and white, and most were from the USA, but there was representation from other countries, Canada, Australia, the UK, and several others. So looking at the diagnosis of POTS and some information from this survey. So the most common age of onset was 14 years. And we can see here in this graph here that there's a sort of a peak around puberty, but still some people are developing POTS when they are a bit older. What was quite striking is that the mean diagnostic delay was 4.9 years. So almost 5 years patients are waiting to get a diagnosis of POTS, which really seems extraordinarily long when we see how unwell these patients are feeling. And then when they did get a diagnosis, 56% of participants reported they were diagnosed by either a cardiologist or an electrophysiologist, and then other patients were diagnosed by other specialties or their primary care physician. So looking at some POTS symptoms, so a large part of the survey was asking about many symptoms, classic POTS symptoms as well as other symptoms. And so not surprisingly, almost all participants reported common POTS symptoms, including lightheadedness, tachycardia, and presyncope, which I think we expect because those are the classic POTS symptoms. What was more interesting, or I think, is the prevalence of some other symptoms. And so this is just a small snapshot of all of the other symptoms that were asked, and there is more detail in the paper. But for example, for the gastrointestinal symptoms, we can see about 80% or more experienced nausea, stomach pains, and bloating, which I think is maybe surprising. It's not what was not considered in the initial POTS criteria in terms of those classic symptoms. As well, headache, difficulty concentrating, memory problems, and maybe cognitive or like neurological brain symptoms. Again, more than 80% of participants reporting that they experienced this. So interesting to consider the other body systems involved in addition to those classic POTS symptoms. Comorbidities were also common. So as I mentioned earlier, Ehlers-Danlos Syndrome, which is a connective tissue disorder, which I will provide more detail on, was common in about 25% of participants. Autoimmune disorders were reported in 16% of participants, and mast cell activation was reported in 9% of participants. And again, that's an allergy disorder where patients have inappropriate allergic reactions that can range from flushing and hives, GI disturbances, all the way to full anaphylaxis. And this table is available in the paper as well. So now moving on to some specific findings in this survey for looking at patients who have POTS as well as Ehlers-Danlos syndrome. So as I mentioned, Ehlers-Danlos syndrome is a connective tissue disorder. It's actually a collection of disorders where there are different identified collagen mutations. I think right now there are 13 different disorders. The most common type is hypermobile Ehlers-Danlos syndrome. Now, interestingly, it's the only type where they actually haven't been able to identify a causative gene. So they are doing some work on that now, looking at POTS patients and identifying or looking at hypermobile EDS patients and seeing if they can identify a gene. But what these pictures show here is different patients performing what's called the Baton score. And so this is part of the diagnosis of hypermobile Ehlers-Danlos syndrome. So patients clearly are hypermobile, quite a bit of elbow hyperextension, as well as these ability to move your thumb and pinky and things like that. So the most common type of EDS associated with POTS is this hypermobile Ehlers-Danlos syndrome. So this is looking now at patients who are diagnosed with POTS and EDS in blue compared to patients who had POTS but not EDS in red. So with these classic POTS symptoms, we can see that the majority of patients are reporting them, which is again not surprising. These are sort of traditional POTS symptoms. We can see presyncope is a little bit higher in the POTS plus EDS group, as well as palpitations. But then when we start looking at some other symptoms, so things like allergic symptoms, so again, POTS plus EDS is in blue, we can see it is significantly higher in all of these allergic-like symptoms. Hives around the ankles and feet was specifically asked because that was something that had been reported by patients as a finding. For me, at least, when I think of Ehlers-Danlos syndrome, especially hypermobile type, think of like the joint hypermobility and the joint pain and things like that. I'm not sure if allergic symptoms would have been something I would have thought of right away. But one thing we're seeing in the survey as well is that there is an association between this EDS as well as the mast cell activation syndrome, which is that allergic disorder. So definitely something to research further, but what might be going on mechanistically here to cause these allergic-like symptoms. Similarly, looking at some gastrointestinal symptoms, we can see again that they're all, so all P less than 0.001 for all are more common, or more participants reported they had them if they had POTS and EDS versus POTS only. So again, maybe for me, not something I would have thought of right away, thinking of EDS or hypermobile EDS, but again, an important consideration that this additional diagnosis of EDS might increase your gastrointestinal symptoms. But then again, with the POTS only group, it's still a significant percentage that is reporting these symptoms as well. And then looking at some neurological-like symptoms, again, we can see that these are also significantly higher in the POTS plus EDS group versus the POTS only. So definitely consideration of the multisystemic effects of having POTS. And then if you have an additional diagnosis of EDS, it seems like you're more likely to have some of those symptoms as well. So then we looked at the quality of life differences. And this is something I presented at the Heart Rhythm virtual scientific sessions this past May. And so this is using the RAND 36 quality of life score. So this is a quality of life scale with 8 different domains, where a higher number means you're doing better, a lower number means you're doing worse. And so again, in blue, if it's POTS plus EDS, and the red color is POTS no EDS. So in the physical health domains, sorry, I just lost my mouse here. Physical functioning, role limitations to physical health, energy and fatigue, social functioning, pain, and general health, we can see that the POTS plus EDS patients have a lower quality of life compared to POTS but with not EDS. but in terms of role limitations due to emotional health and emotional well-being, it wasn't different. Then when we look at the composite scores, so this is using those individual domains to create composite scores, we can see that for physical health as well as general health, the patients with POTS and EDS are experiencing a lower quality of life. So it's possible that the added burden of having an additional diagnosis and these symptoms are contributing to worse physical related quality of life in patients with EDS and POTS. So now switching gears here and looking at a little bit of sex differences in the diagnosis and impact of POTS. So we know that the majority of patients are female, and we saw that as well in the survey where over 90% of patients were female. But what I think is very interesting in the survey is that the diagnostic delay was almost 2 years longer in females than males. And this is very surprising considering this is a disorder that is primarily affecting females. What's also interesting is that both males and females experienced misdiagnosis at similar rates. So it was like 76% for females, 75% for males. And despite this, and despite the fact that they both saw the same number of doctors before diagnosis, females were waiting 2 years longer than males. Additionally, females were more likely to be told that their illness was all in their head or it was just due to a lack of exercise. So I think that factors like that might be contributing to this extended diagnostic delay in females. But again, this is a disorder that primarily affects females, so it's definitely an area to work on in terms of reducing that diagnostic delay. Looking at comorbidities in females versus males. So more females than males reported that they were diagnosed with at least one comorbidity, and then more females than males said they had EDS as well as mast cell activation syndrome. I'm not sure. It's an area that requires sort of more investigation as to why that might be, but definitely seems like there's a higher comorbidity burden in the female patients compared to males. So then this is looking at quality of life. And so this was something that was accepted for a conference that was canceled due to COVID, but will hopefully be presented this year. And again, this is that RAND 36 health-related quality of life. So we can see lower score means you're doing worse, higher score means you're doing better. Females are in red and the males are in blue. And so we can see for, again, all of the physical health related domains that females have a worse quality of life than males, but in the three sort of emotional health domains, role limitations, emotional health, emotional well-being, and social functioning, it's not significantly different. And then again, looking at those composite scores, so physical health and general health was lower in females than males. So I'm not sure exactly why. It could be that the added burden of the comorbidities that the female patients have could be contributing to their lower quality of life. Maybe their longer diagnostic delay and longer time to treatment could be contributing as well. But again, an important consideration in this data set. So now continuing with this diagnosis and impact of POTS survey and looking at some economic and employment impacts. And so this is something that Dr. Derek Chu worked on with me, and he was able to contribute his economic expertise to this analysis. So looking at the survey, so only 48% of participants were employed in the 3 months prior to the survey. So less than half of the population was working. And 67% said that they would like to work more, but they were limited by their POTS and the POTS symptoms they had. As well, 82% had called in sick due to POTS, and 74% were unable to work for a period of greater than 1 week. So definitely significant limitation there. I think, again, something that maybe isn't considered. You think of POTS, you think of, oh, patients feel bad when they're standing, but if they're sitting, they must be fine. And that's not really the case in terms of all of these other symptoms that these patients experience, and clearly having an impact on their ability to work. So challenges with employment. So 21% of participants indicated they actually had lost a job due to POTS, and 72% had had to modify a job due to POTS. So 55% with workplace reductions, 74% with schedule reductions, and 67% with other modifications. So for those participants who are able to continue working, the majority are having to modify their job in some way to be able to continue. And now turning to economic impacts. So 71% of participants indicated they had lost income in the 12 months prior to the survey. So the majority of participants, with 36% indicating they had lost $10,000 US or more. So in addition to significant impacts to being able to work, there's also a significant income loss associated with POTS and the limitations it presents in terms of employment. Turning now to disability benefits. So this is did you apply for government disability benefits? And 34% indicated they had. 12% had indicated they'd applied for private disability benefits, and that's shown here. And then looking at success rates, it was 64% for government and 74% for private. So a bit surprising to me that if we saw less than half of participants were working and 70% had lost income, that only a minority of participants had actually applied for benefits. The success rate isn't terrible. It's above 50, but considering these impacts on patients, it would be nice if it was a bit higher, because clearly these patients are experiencing significant challenges in terms of working and earning an income. Okay, so that was just sort of an overview of the diagnosis and impact of POTS. It's a very comprehensive survey, and so that's some of the areas that we're working on, and there definitely is a lot more exciting data to look at in that survey. So turning now to non-pharmacological treatment. So this is just a little diagram that I made. So we have here a POTS patient who's sitting and they seem to be relatively okay. But unfortunately, they've stood up and something has gone wrong. So they stood up and gravity has pulled blood from their chest down into their abdomen and legs. And this is leading to a rapid heartbeat, lightheadedness, fatigue, and blood pooling in their lower body. So with treatments, we're going to try and target some of these things to help them feel a bit better. So one treatment that's prescribed in POTS is exercise, but this is sort of in a very specific way. Obviously, if someone is standing and their heart rate is already 200 just from standing, if you ask them to go for a run, that's not really going to work out super well. So I think recumbent exercise, rowing machine, recumbent bikes, swimming, in a very graduated and fashion is what is prescribed. Increased salt, increased fluid intake, and then as well compression garments. And hopefully some combination of that will help the patient feel better. There are medications that are used. They're all off-label use. I'm just not specifically talking about them here, so I didn't include them, but medications are as well a part of the treatment and management of POTS. So in the CCS guideline statement that I mentioned, there are some helpful schematics. This one is a treatment schematic, so it shows the non-pharmacological treatments as well as then some medications. And this is an open access paper if you're interested in going in and looking at this in more detail. But in terms of the main non-pharmacological treatments, so obviously withdrawing medications or anything that is going to be causing tachycardia, 3 to 4 liters of fluid a day, 10 grams of salt a day, exercise, as I mentioned, as well as compression garments. So my research has specifically focused on compression garments, so that's what I will be focusing on now, and sharing some recent findings from this research. So this is a figure from Andre Diedrich and Italo Biaggioni down at Vanderbilt, and this is looking at bioimpedance and fluid shifts in a healthy person. So when the impedance increases, it means there's been a fluid shift away from that area. So we can see with upright posture, my mouse disappeared. There's increased fluid in the lower torso, as well as in the thigh, and then in the calf, but not quite as much. So the majority of it is pooling in the lower abdomen. And then we see that fluid shift away from the upper torso. So why compression garments? So when patients stand up, we know that blood is pulled down to the lower body, and that in POTS patients, the body's ability to regulate or manage standing is disrupted. So compression garments actually provide mechanical pressure or mechanical squeezing to the abdomen and lower legs, with the idea being that if we can squeeze the lower body and shift blood back to the central circulation, so to increase preload and stroke volume, then the patients should be able to maintain their cardiac output without excessive tachycardia. So that's the idea there, and they're frequently prescribed in POTS patients, but there's actually been no study in an adult POTS population looking at whether or not they work. The other thing that's nice about compression garments is that you can target a wide group of POTS patients. Probably most POTS patients have some feature of blood pooling in the lower body. So while we don't fully understand all of the mechanisms, this is sort of something that can be broadly applied across the POTS population without needing to have a specific drug or a specific understanding of a very detailed mechanism at this point. So this is what we did. We did a study looking at compression garments. So we use this garment here. It's called the Life Wrap. It's normally used in developing countries for postpartum hypovolemia to prevent hypovolemic shock. But it's something that we chose to use for a couple of reasons. One of them is that these segments can be done up and undone in different arrangements. So we could recreate the action of different types of compression garments. The other reason we chose this is that it can be sized to multiple participants. It can be used on more than one participant. When you go to get medical grade compression garments, they have to be sized. It's very specific, and that would obviously be very cost prohibitive if we had to size every single person in the study. So this was a randomized crossover trial where we did 4 10-minute head up tilt tests in a one study day. Each participant did all 4 tilt tests, and for each tilt test, they wore the garment in a different way, which I will show on the next slide. And again, that was in a random order. We had 30 participants in total. 28 were female, which is expected for the POTS population. The mean age was 32. And the mean BMI was 24. And this research was recently accepted at JAC. It's currently in press and will hopefully be available soon. So this is just a diagram or a drawing that shows the different compression garment configurations. So no compression applied, lower leg, which was to represent like a pair of compression socks, abdomen, which was to represent Spanx or a type of compression short that would compress sort of the thigh and abdomen, and then full, which was simulating full waist-high tights. And so again, each participant did 4 tilt tests, and for each tilt test, they were wearing one of these conditions in a randomized order. So jumping into the results here, so this is showing the heart rate both during the baseline and then during the head up tilt, with no compression in blue and then full compression in purple. So what we can see is when the patient is tilted, their heart rate was highest with no compression and lowest with full. What was exciting to us, and I think something that we maybe didn't expect, is that there was this nice dose-dependent trend, and dose-dependent meaning area of body compressed, where we can see that the heart rate was a little bit lower in leg in red, and then a little bit better in abdominal, and then a little bit better in full. So a very nice separation there in terms of benefits and heart rate reduction. Looking at the delta heart rate, so this is going to be heart rate upright minus heart rate supine. So we know that the POTS heart rate criteria is 30 beats per minute or more. And we can see that with no compression applied, the mean heart rate increase was approaching 40. And then when we get here down to full, we can see it's actually reduced below the 30 beat per minute criteria. So definitely a positive effects with this compression garment in terms of heart rate reduction. Looking at symptoms as well. So obviously it's great if the heart rate is reduced, but how are the patients feeling? So we use something called the Vanderbilt Orthostatic Symptom Score. So this is something that has 9 different symptoms that the patients rate from 0 to 10. So the score can range from 0 to 90, with 0 being no symptoms at all and 10 being like a worst ever situation. So again, we see a similar dose-dependent response where participants had the worst symptoms with none, a little bit better with leg, better with abdominal, and then the best with full. So exciting result. In addition to heart rate being reduced, the patients are actually feeling better. Then looking at blood pressure. So this is similar figures where we have the baseline and then the tilt. We can see in the full compression that blood pressure was best preserved in full compression and was the lowest in none, with again that dose-dependent separation occurring. And then again, the delta values, we see something similar. For none and leg, it was basically the same, but then abdominal preserving blood pressure a bit more, and then full the best. So this is just looking at blood pressure decrease comparing tilt to baseline blood pressure. Then again, stroke volume. So we can see stroke volume was best preserved in full and dropped the most in none, again with that dose-dependent separation. And then looking at the delta values, better preserved in abdominal and full, not as well preserved in none and leg. So definitely exciting findings there in terms of getting this very nice separation between the 4 different compression conditions. And that patients had lower heart rates and were feeling better. We also noticed, so this is looking at the none head up tilt. Each dot is a participant. That participants separated themselves into these 3 sort of different categories. So we had participants whose heart rate increase was below 30. It's important to note that all participants in the study had a diagnosis of POTS that had been confirmed, but we didn't require holding of medications, as this can be quite prohibitive to participation in the studies, and because participants did all four tilts, they were kind of acting as their own controls. So some of these participants here who did not quite meet the 30 criteria were on medications. Then there's some participants here in the 30 to 50, and then there are these super overachiever participants whose heart rate increase was 50 beats per minute or more, approaching 80 in this case for this patient. So what we wanted to know is, based on your heart rate increase with no compression, was your response to the garment different? And so that's what we looked at here. So this here is just showing the heart rate increase for the three groups. So again, this is that less than 30 group, the 30 to 50 group, and then the 50 plus overachiever group for both no compression and full. And we can see in both cases, the heart rate was highest in that 50 plus group. And then now this is looking at the difference between the heart rate on none and the heart rate on full. And we can see the heart rate reduction in the greater than 50 group was significantly higher than the heart rate reduction with the garment in the other two groups. So it's definitely something where if you have a patient who has more significant orthostatic tachycardia, they might benefit more for compression, but if their heart rate is already well controlled with the medication, they may see less benefits or effects from using a compression garment. We also asked the patients, what did they think? That's obviously important. That's obviously important in terms of outcomes. And so this was asking the patients, with the compression garment compared to none, how did you feel? So for example, like for here, this is with the leg compression, how did you feel compared to none, abdominal, and then full? We can see that for leg, almost 50% said they felt better. Over 50% said they felt better with abdominal, and then almost or about 80% said they felt better with full. And that's consistent with our heart rate and blood pressure findings. So again, another confirmation that the patients were feeling better when they were wearing the compression garments. But we did want to take this a step further to learn a bit more. And so I did a qualitative study where I wanted to talk to POTS patients about their experiences with compression garments. And so we interviewed 20 participants who were diagnosed with POTS, 19 female. Again, that's representative of the POTS demographic. All participants had said that they had tried compression at some point in time, and over half indicated they were still using compression. What was really interesting is that they reported mixed experiences. So some participants said, 100%, this is so helpful. I wear this every day. I couldn't function without it. Some patients said, not really sure. It seems like it's helping, but maybe it's not helping. Can't really tell. And then some patients were like, definitely this was awful. It was not helpful. So I don't know if that maybe leads into a little bit of like differing mechanisms of POTS and what might be going on, but that was quite interesting. And then patients also participated in a cost benefit analysis. So for this one patient here, she's basically saying like she wears the garment so she doesn't faint and get a concussion, but it's not, you know, the most comfortable thing. So that was sort of an interesting comment, I thought, and definitely lends into needing more research to understand the mechanisms of POTS, but compression garments do really seem like a promising option in the interim that can be applied broadly across the POTS patient population. So just to conclude, so POTS patients experience a significant symptom burden and impacts to multiple areas of their lives. More research is required to understand the underlying mechanisms of POTS and related conditions, and to be able to develop targeted treatments. And then we've shown that body compression does reduce orthostatic tachycardia and symptoms in patients with POTS. And this is something that had not previously been evaluated in an adult POTS population. And I'd just like to acknowledge Dr. Raj, as well as all of the Raj Lab team members, my committee members, as well as my mentors and collaborators, and then the Vanier program for funding my research.
Great, Kate. Thank you. That was a fairly quick whirlwind tour of POTS, and clearly reflects some of the great work that you've been doing. So there are a few questions in the chat, and I'm happy to throw some out to read there. So one question from Dr. Mitchell is that these patients seem to stop coming back as they age. He's wondering if the symptoms spontaneously resolves, or if it's something about him that he should be worried about.
So I don't know if we know that for sure. I mean, I know that physiological orthostatic tachycardia decreases with age, and there's some thoughts that there could be involvement of female sex hormones in the being more at risk for developing POTS. So yeah, I'm not sure if we know that yet. There hasn't really been a lot of long-term evaluation, but I think that it seems like a common report that patients might get better as they're older.
I think on behalf of the division, Dr. Mitchell, it's them, not you. Carlos asked a question that you sort of touched on a little, and that had to do with the long-term compliance with the garments. He indicated that they weren't fashion forward enough for him, and that he wouldn't wear them.
Yeah.
I wondered if you want to sort of touch on that a little more in terms of some of the insights that you have on garments, both from the patients and otherwise.
For sure. So in the qualitative study, which was very helpful, there were some different things that patients talked about. So some patients reported that they wore like athletic tights, so triathlon tights or things like that. And they mentioned that it just seemed like they were going for a run or they were going for a bike ride. And so that helped them blend in more. Other participants said that the benefits of the compression garments were so great that they actually didn't care what they looked like because it was preventing them from, falling or fainting or having severe symptoms. So I think at least in that study, if the participant experienced significant benefits, I think that their concern about the appearance wasn't great, but maybe if they didn't experience strong benefits, then they were more concerned. And then some patients had opted to use the triathlon tights, which looked more, as they said, like fit in with society and didn't look weird, using their words.
Yeah, Kate, that was great work. You did mention at the beginning that there were like 3 types of mechanisms for POTS, like, hypovolemic, the hyperadrenergic, and the more neurogenic. Do you think that, we can kind of identify these people with the autonomic test and then tailor medical therapy based on that?
That's a good question. I'm not sure if it would be. I think you would have to do like you could do like blood volume analysis, or you could do some sort of like muscle sympathetic nerve activity testing or things like that. But I'm not necessarily sure if there would be specific treatments. Now I know like for patients with hyperadrenergic POTS, you can give them like methyldopa or clonidine or things like that. But I don't know if we're quite there in terms of typing patients and then tailoring their treatment.
So there was, so I think Kate's absolutely right. We can respond to features, but there isn't good data on drug response necessarily by type. And there's one sort of exception. It's a bit of an odd trial, but it was done by Julian Stewart. It was a physiology-based trial where they had broken up patients into low leg blood flow and high leg blood flow, but that probably correlate with neuropathic versus hyperadrenergic in terms of how much squish you have. And there was a difference in response to mitogen. And so the patients with the higher flows, who presumably weren't squishing when they got the mitogen, they actually improved more in terms of symptoms and heart rate than the patients with low flow. I mean, that has to be tested prospectively on the front end. That's what they found. But otherwise, I think we use the features that we find. So if someone is very revved up, we, as part of our autonomic testing, we fairly commonly, almost routinely, get supine upright plasma catecholamines fractionated, so we can get norepinephrine levels in these positions, and that can sometimes guide whether an aggressive approach with like methyldopa, central sympatholytic, is helpful. Blood volume assessments aren't easily available clinically. There's actually a meeting I have later this week with someone to try and see if we can get some of that approved in Canada that we used a lot when I was in the States to try and guide therapy. And in fact, I think one of my colleagues at Vanderbilt is actually going to be putting in an NIH grant to try and look at sort of a tailored therapy approach, just as you say, Carlos.
Yeah, we're doing some of that work in Hamilton with Juan. When we used to give people phentolamine, phenylephrine, look at alpha-adrenergic response and things like that, and try to figure out that these people would be more responded to metadrin or to prednistigmine, things like that. But it's not that easy. Now, one of the things that you showed in one of the tracings at the beginning was the blood pressure response during tilt in POTS, which is very different from the control response. Now, there's no orthostatic hypertension, but if you look at that, it's like a 0.1 hertz cyclic baroreceptor thing going on all the time. Have you guys looked into looking at the spontaneous baroreceptor response in the different types of POTS, and also what does the garment stuff do to that kind of response and blood pressure variability?
I don't, that's not something that I've specifically looked at yet, but I think that would be interesting. But it might be something that I'm not sure if other lab members have looked at that in terms of other data, but it would be interesting to look at.
Yeah, when you look at overall groups, it can be all over the place. But I think you're absolutely right. I think they actually represent Meyer waves and sort of the body's attempt to try and maintain the pressure. So it's falling and then it squishes and it's really on a roller coaster. But it's not a bad idea. Kate does have a nice data set, and we certainly are going to be capable imminently. We're redoing our analysis software a little, but of getting blood pressure variability as well as different metrics of baroreceptor sensitivity. So it's a great idea.
Yeah, because well, my point would be, you could look at the garment and see, when you can actually predict that change in blood pressure variability. And eventually that would predict response and reduction in symptoms.
So we'll definitely look.
Because, we did some work also with Juan way back then in POTS, and we did show that, this 0.1 hertz Meyer waves were actually quite important in patients with POTS, and they were frequently affected. And those that responded to treatment actually were the ones that you kind of abolished that 0.1 hertz frequency. So there has to be some way in which you're kind of entraining that loop of the baroreflex in which you can eventually improve symptoms in these patients. So maybe something you guys can look at.
For sure.
So there's another question from iPhone in the chat, and it was sort of two questions actually. One is about the role of body mass index, presumably in POTS more generally, and then about medications that could actually worsen or induce POTS.
Okay, yeah. So I feel I'm not familiar with the role of body mass index in POTS. Dr. Raj, I'm not sure if you're aware. But in terms of medications that could worsen POTS, so things like stimulants, ADHD type medications, any sort of like norepinephrine reuptake inhibitors, spironolactone containing medications, because it has like a diuretic effect, I think, are some that could cause a problem.
So just to amplify the drugs, I mean, some of these drugs are not where you think they are. So a lot of the norepinephrine transport inhibiting drugs are neuropsychiatric drugs, right? So they're anything that's an SNRI drug. The N is actually blocking this transporter that Kate's talking about that can worsen POTS. So Cymbalta is, for a while was a very hot and sexy drug in the fibromyalgia and chronic fatigue world, and so there'd be a lot of crossover, and that can worsen symptoms, not in everyone, but in a lot of POTS patients. The spironolactone one is interesting because there are a few POTS patients I've seen on spironolactone. Interestingly, almost all teenagers who are on it for acne. And sometimes the treatment is if you can just get them onto something else for their acne, a lot of their tachycardia and symptoms in terms of blood volume regulation improving gets better. But I'm blanking on the birth control that was very...
Is it Yaz or something?
Yeah, Yasmin were very popular birth control agents a few years back until lawyers in the States sort of chased them down for DVT issues and PE issues. But it's an interesting drug because they made the claim that they actually fixed PMS, which the FDA slapped them back for. And then they made the claim that they helped with premenstrual dysphoria syndrome. But it may well have done something because the progesterone agent in that birth control is a drug called drospirenone, which is a spironolactone analog, right? And so a lot of what it may have been doing is blocking some of the aldosterone effects, that tend to peak and associated with fluid retention around menstruation. But the consequence is that they work by causing blood volume reduction because of that. And so in a lot of our patients, I'd be lying to you if I told you that stopping that fixed everyone. That's not the truth, but there are some patients that noticed improvement when they switched to another birth control agent with a different progesterone component. So drug can certainly, accentuate the problem, and in some cases, take someone from minimal symptoms to significant symptoms.
The body mass index is an interesting question because, Ben Levine has this theory of the Grinch thing, that it's mostly a small heart, and women are more affected because they have a small kind of hypovolemic heart. So, but as far as I understand, he's always corrected for BMI, and that doesn't really have a role in his theory. So,
But the one thing I'll say is that if you were to look at the spectrum of POTS patients by size that come to our clinic, but I think come to most clinics, and Carlos can comment on his experience when he was in Hamilton, is that they tend to be normal to low in weight on average, right? So are there POTS patients that are obese? There are a few, but certainly compared to society, I'd say they're much less so. Like you're more likely to have an underweight POTS patient than an overweight POTS patient. And I think part of the Libin protocol that we don't pay as much attention to is it's mainly an aerobic reconditioning, but they do actually suggest a little bit of resistance training for the thigh muscles on the lower legs. And the main issue, I think, is that there are some, not all, but there's some POTS patients that are sticking, like skin and bones, right? There's really no appreciable muscle bulk. And I think the goal was by building up a bit of muscle bulk that it can act as a fluid reservoir, right? So there's blood that stays in the muscle that can be deployed into the vasculature at certain times and then be undeployed. And without that muscle bulk, you lose that a bit.
yeah, I would agree.
So there's a comment here, Kate. It's not so much a question, but if the person that asked it wants to ask a question, that's great too. It's a PhD candidate in pharmaceutical health services research who also suffers from POTS herself, and she wanted to congratulate you and is happy that you're doing this research that she thinks is desperately needed to improve the outcomes and quality of life in POTS patients.
Oh, thank you so much.
We have any other burning questions? We have a couple of minutes left, but the hour is almost up.
I have one question. It's Steve Wilton about, I remember hearing you talk, Satish, before about this drinking lots of fluid first thing in the morning before getting up. Is that something you're still recommending, or is there any new data about that?
Right. So that actually is more, so that's something we recommend more to orthostatic hypotension patients, in particular neurogenic orthostatic hypotension patients. So what Steve's talking about is a response that colleagues at Vanderbilt before I got there backed onto from patients telling them actually that they felt better when they drank a tall glass, so half a liter of cold water. And so enough people had said it, and particularly engineers will come in with lots of numbers documenting that what they're saying is real and not made up in terms of blood pressure. And so they did studies first in a cold room thinking that temperature was the issue, and that made no difference. And then looking at room temperature water, and it turns out in patients with autonomic failure, but not POTS directly, um, chugging, so getting down within 2 or 3 minutes, half a liter of water can cause a transient increase in the systolic blood pressure, averaging between probably 30 to 40 millimeters of mercury in systolic blood pressure. Short effect, peaks within 20 to 40 minutes, and it goes away. And the key is it's the Seinfeld response. If those of you that watched Seinfeld back in the day know that they did a series of episodes discussing what the show was about, and it turns out the show is about nothing, absolutely nothing. And that's the key to the water response. This works with water. I did it. One of my early studies at Vanderbilt was we compared water and half normal saline, so salt water ingestion, and the salt water worked half as well. And so there's a series of work done with 2 PhD students in mouse models. And the long and the short of it is that acutely drinking plain water alters the portal vein osmolality transiently. And that actually triggers residual sympathetic tone that causes an increase in blood pressure. So when this has been looked at in POTS patients, there is a small decrease in heart rate, right? A couple of beats a minute, not a huge response. So we recommend hydration, aggressive hydration. So 3 liters of water intake a day, but not necessarily the chugging water in this population.
Okay, thanks. Obviously, I misremembered that tidbit.
Okay, well, thank you both. That was great. I just want to congratulate you both. And Satish, you've done a great job mentoring all these people in your lab and getting great publications. You know, Kate publishing in Jack is a treat, and congratulations for that. Thank you both. Thanks,
you.
Satish.
Thank you.